Welcome to Midwives, a Metro Midwifery podcast. I'm Gina Gerboth.
And I'm Nedra Hale, and we are home birth midwives serving the Denver metro area. Today we're going to talk about newborn screening. One, because September is National Newborn Screening Month, but also because we, Gina and I, really feel strongly about the value of newborn screening. Yes. So we're actually really excited to talk to you about this.
This is when we know that we're really big nerds.
Yes, it sounds very, as I was talking, I was like, ooh, we sound like really exciting people.
But we are really excited. And we were even like, oh, this one will be so fun to do.
Yes.
Good.
Okay, so there are 3 parts to the newborn screen. One is the blood spot test, which is probably what most people are most familiar with. And then there's the CCHD screen that Gina's going to talk about, and the hearing screen. So why don't we go on with you, Gina, and we'll talk about the CCHD.
Sure. So CCHD stands for critical congenital heart defects. And what's interesting is that actually congenital heart defects are not that uncommon. They happen about 1 in 110 cases. Which I was surprised by that information.
Yeah, I'm surprised that it's so common.
But about 25% of those would be critical, meaning that they really need to be caught and treated early. Mm-hmm. So the CCHD screening is meant to catch those critical defects, but it won't necessarily catch every heart defect that's out there.
Okay.
So again, these are all screening tests, not diagnostic tests. So these are just kind of taking that first look and figuring out who's at more risk to having a disorder.
Okay.
So the critical congenital heart defect screening, I'm now going to call it CCHD,
yes.
Such a mouthful,
yes.
is a very easy, non-invasive test. And all it involves is using a pulse oximeter in 2 places on the baby's body to check their oxygen saturation. And what we're looking for is oxygen saturation that's over 95% on one of the areas and not more than 3 points different on the other area.
Okay.
So there's different algorithms, and that's the American Academy of Pediatrics algorithm.
Okay.
So we always test the right hand, and we can test either one of the feet. And what that's doing is checking the circulation of the blood. How is the heart pumping the blood through the body?
It doesn't matter which foot.
It doesn't matter which foot.
But if the baby doesn't have a right hand? I'm asking that because I have had that.
A baby without a right hand?
Yes, an amniotic band.
Uh-huh.
Yeah.
Uh-huh.
So I assume you can do it on the left hand, right?
Well, I don't think it would be preductal on the left hand.
Oh, dear.
That would be a question to ask your pediatrician.
Okay, all right. That sounds good.
You would have to throw a hard one out right at the beginning. I imagine you could do it on the wrist or the arm. What as far down as you could get would probably be doable. But I don't know that for sure. So it would probably not work with the pulse oximeters that we carry. Mm-hmm. It would probably be doable with special equipment.
Assuming that we know that this condition is there, which we did in this case, we would have to do some pre-planning on how to handle that.
Yeah, mm-hmm. That would be an interesting research process. And so we should say that this is kind of new. So probably there wasn't CCHD screening at the time that you had that birth.
Oh, yeah.
It wasn't part of the standard.
It was so long ago,
mm-hmm.
Yeah. No.
I think it was relatively recently added to the newborn screening panel and even later adopted by community midwives and community birthing mm-hmm. locations. So this is really something that's just kind of, I don't want to say new on the scene, but newer on the scene.
Yeah.
So the process is really simple. There is some expense involved for the midwives, of course, to carry the equipment. Some states offer rebates, or sometimes even the state health departments might pay for the equipment. So if you're a midwife in another state, that's worth looking into. In Colorado, we're kind of on our own with acquiring the equipment. Something important to know about critical congenital heart defect screening is that as you go up in elevation, the accuracy of the test, the sensitivity and specificity of the test go down. So it becomes less useful of a screening tool at high elevation, which we absolutely encounter here.
Yes.
Even in the suburbs of Denver, we can easily be above 7,000 feet, which is sort of the cutoff. So, so we don't screen those babies, and that's okay.
Mm-hmm.
We might still test their oxygen and make sure that they're holding their oxygen well, but
it's just not the formal
it's not part
test.
of the screen. Mm-hmm.
And there's, what we used to do, all the visual indicators of heart defects and
we're
O2
listening
saturation.
and all of that. So
Yeah.
at elevation, so what happens is they tend to quote unquote fail the screen, and then they have to go. The next step then is to go in for an echocardiogram, which is a pretty expensive test. And so they were just finding that the cost benefit of screening babies that weren't going to pass and the effort of taking them to Children's Hospital. And
so that was one of my questions, is what happens if a baby does not pass this test?
So if they don't pass, they get referred out to, I would just send them right to Children's Hospital and have them screen them right away and start the process there. I mean, I would send them to the emergency room. Or if you had a pediatrician, you could call and ask them what to do. They would probably send you to the ER. Now, not every hospital has the ability to do this testing, and you might end up getting referred up quite a large chain of hospitals and that kind of thing. But we are fortunate to have 2 regional NICUs in Colorado, or in Denver. So we have the facilities available to us. So I feel lucky about that.
Yes, definitely.
So interestingly, I've only had one baby with a critical congenital heart defect. And more interestingly, she passed the test.
Oh.
So
well, that's complicated.
It is complicated. But she had what's called coarctation of the aorta, which is considered a critical congenital heart defect. And it's one of the ones that's more likely missed on the screen.
Okay.
So she did need to have it repaired. It wasn't an emergency, but it was certainly something that needed to be addressed.
Okay.
So then, like you said, the one that most people equate with newborn screening is actually the blood spot test. A lot of times people call it the PKU.
Oh, yeah. I forgot about
it's
that.
Still
really?
People call it the PKU.
Oh.
And PKU is just one of the tests.
Yes, it's on there.
It's on the panel, but that's just a tiny bit. But you might hear it be called the PKU, the metabolic screen, or genetic screen. More appropriately, it's a genetic screen because not all of the conditions are metabolic.
Okay. Yeah, I call it a metabolic screen.
Well, like cystic fibrosis, there's just a few on there that are.
That's a good point.
So blood spot, but I think blood spot's the worst name, but it's the most
I actually
descriptive.
Didn't know we called it a blood spot test until we started putting this podcast together. So, I mean, clearly it is a blood spot test, but I just have never called it that or heard it called that.
Sad.
It does. It's not very nice. So I don't really have a feel for how long we've been doing newborn screens with the blood spot test, or how widespread it has been. But
I believe it's been since the 50s or 60s.
Okay. I know. I mean, we've been doing it since I started, at least, and I've always felt really strongly about it. So what this is looking for are a number of different disorders. So we've got amino acid disorders, endocrine disorders, we've got acid disorders, organic acid disorders, cystic fibrosis, fatty acid disorders, galactosemia, hemoglobinopathies, and what is this one? Oh, severe combined immunodeficiency. And what am I missing?
Does
that sound pretty?
That sounds pretty thorough.
So there's a whole bunch of stuff. In Colorado, we are currently testing for 44 different things.
So how many is
test
potentially able to be tested for?
I did a little bit of research on that, and the highest number I came up with, let me look at my notes here, was in Illinois at 64. I don't know if that is, I didn't look at every single state.
The maximum.
The very maximum, but I found many states actually that test for more things than Colorado does, and a few that test for less. Interestingly, Arizona, where I came from, just tests for 31, which I think when I started, it was more like 27. So
which
we've added a
actually in
few.
12 years, not
Not a big improvement.
not a big addition of testing.
Yes. The reason why these tests are so important is that when we catch these things early, many, many, many times they can be treated, pretty successfully, depending on what the situation is. It might be with a change in diet or medications, certain special foods, maybe. So it's just so important. And I personally have had babies in my practice that came back with one of these disorders. So the hemoglobinopathies are super common. I've seen a couple of those.
I've had one as well.
Yeah. And I had a congenital hypothyroidism come up, and this poor baby had no thyroid function at all.
Wow.
So it was really important to know that
So
that
important.
was true.
And those aren't the critical conditions. If your baby has something like galactosemia, they can have brain damage or death in a matter of days.
Right.
They really need to be caught and treated as soon as possible.
Yeah. Yes.
So the timing on them, I was going to say
yes.
too, is really critical. This is kind of a misconception among some practitioners. Sometimes it's even nurses in the hospital. Sometimes it's midwives. The idea that you can wait a little longer and get a more accurate reading to test.
Oh, yeah.
Have you heard that before?
I have heard that.
When in actuality, if you waited, a few days or a week to test, you would lose some babies.
Yeah, if we had something like galactosemia, that would be, we would have missed a really important time to intervene. So in Colorado, we are supposed to test within the first 48 hours, and the second test would be at 1 to 2 weeks.
Between 8 days and 14 days.
So I have historically tried to hit about 10 days, split the difference.
10 days is a good time to see the family again anyway.
So it coincides with with a natural postpartum visit. Sometimes I've had families that wanted to just do one or the other, but I've always pushed that it's just really important to do both. You might miss something on the first one that will come up on the second one. There might be false negatives on one or the other. We just need both.
And what I learned recently, I don't know if anybody read the blog post, but I was involved in a project called the New Steps program, and it was a couple educational videos for midwives and newborn screening. And what I learned in that was also that, one of the reasons that midwives are sometimes not as enthusiastic about the newborn screen is because there can be false positives. And I've had a false positive.
I have too.
Where you get a positive and you send them in for more testing and
Yes.
it turns out to be normal. And then that's really discouraging sometimes. But one thing about testing outside of that 24 to 48 hour period is that you're going to get more false positives because the reference ranges change over time. So, when we talk about when people are pregnant and we look at lab values and they'll say, but my white blood cells are high. And we'll say, well, no, that reference range isn't normal, isn't in the norm for pregnant people. That same is true for newborns, and the reference ranges are specific to 24 to 48 hours. So it's really important to test in that period of time for the first one. The second one has more leeway, like you said. But not all states do the second test.
Oh, I didn't come across one that doesn't do the second test. Can you think of one?
I am not sure off the top of my head, but there are some states that only do one test, which means that they're more likely to miss the more common conditions like congenital hypothyroidism, because that's more likely to not be captured on the first screen.
I want to talk a little bit about how we do this test, and then a couple of the questions and concerns that people have vocalized to me anyway, and I want to hear yours too. So the way that we do this test, as you might have put together from what we've already talked about, is that we have to collect blood spots, and we do this by doing a heel poke with a lancet. And so we've worked really hard. We as midwives, I think, across the world have worked really hard to make this as nice and painless as possible, but there's no way to get around poking the baby's foot. So my routine, I think yours as well, is
that I learned from you.
Oh.
I do what you do.
So I like to put the baby over mom's shoulder, maybe dad's shoulder. And I've tried it with breastfeeding. That works too, but the gravity piece isn't quite as good. So over the shoulder is probably my preferred method. And then we get a nice pull of gravity to help the blood to flow quickly, which is really important. We have to fill several blood spots, and then the parent can be talking to the baby and soothing the baby, and we try to do it as quickly as possible so that we can get right to the comforting part. And then we have to, like we talked about, repeat that. So it's twice that we're going to do this. The questions and concerns that I've heard, I mean, there have been definitely questions about the timing, and they've heard different things. And so it seems like there's a little bit of inconsistent information out there. So, and do we have to do 2 and all of that? I've also heard people being concerned about how the blood is stored.
I've heard that too.
And, that there's blood out there with the baby's identifying information on it and all of that. And so I did a little bit of research into that, and the way that that's handled also varies from state to state. But in Colorado, what I found out is that they keep those for 6 months. And at that point, the baby's identifying information is separated from the blood, and the blood spots are destroyed. And then they keep the baby's information for 5 years. And that's mostly just like the test results part. So separated from the blood, the results are kept for 5 years. Interestingly, I found out that parents, if they are concerned about the state having the newborn screening card on file, they can actually go get it. And if it's within the 6 months before they are destroyed, they can contact CDPHE and go and get it. And they can privately store it, or they can destroy it.
Yeah, that's great. I came across that. I did another project with the public health degree. I've done a lot around newborn screening, actually. But another project I did was to interview midwives and find out what their rates of participation were and what the barriers were. And that was a concern of many families and even some midwives about the storage. So, but there's a lot of misinformation out there for sure. That's great that they can go get it. Oh, I wanted to mention that I know that I've presented information this way, and I know that I've heard it presented this way to say, there's a number of disorders that we're checking for, and they're all really rare. And that's true. Some of these disorders are really rare, but when you add them all up and you add up all the risk, a baby has a 1 in 300 chance of coming up positive with or being actually diagnosed with a disorder.
That is more common than I had thought.
1 in 300. That is not, and it's not surprising that you've seen it several times in your practice.
That makes sense.
Yeah. So these are not like theoretical conditions. These are things that can really happen and really impact your baby's life and potential. Anything else on the blood spot?
I don't think so.
Yeah. So the third test in the newborn screening panel, or the newborn screening program, is the hearing screen. And congenital hearing loss is considered one of the more common congenital abnormalities or anomalies. And it occurs at about a rate of 2 to 4 per 1,000. So even though the other conditions are more common, they're not necessarily like anomalies, whereas there could be a hearing anomaly.
Okay.
Again, the timing is important of the hearing screen, although you have a lot more flexibility for this one. What we do know is that if you don't identify a hearing loss in the first 6 months, the child is more likely to have some cognitive and speech and learning deficits. So catching it in the first 6 months is kind of that critical period.
Okay.
But what's interesting is that if people aren't screened, as infants or in the first 6 months, the average age of identification is 4 years of age.
So that kind of argues against that old thing that we used to say about clapping your hands and seeing if they can hear.
Yep, because babies are awesome compensators. And
yes.
My son, actually, one of my children, has a congenital hearing loss in one frequency. So it's not anything that's impacted him, but he has a hearing loss in one frequency, and he was not screened as a newborn.
So when did you find this out?
In middle school.
Oh.
Because we homeschooled for a long time. We missed a lot of those the school screenings that they do. And so we didn't discover it until he was in middle school. It did not impact his cognitive development, but it does give you pause and makes you think about, wow, you really could miss an important thing. So the process is really simple. We actually have the equipment to do so here at the office. We try to do it early in the visit because usually the baby comes in asleep. They're either in the car seat and asleep or still in the parent's arms and asleep. Mm-hmm. So as long as they're pretty quiet and or nursing, you can do the screening. If they're upset, you can't do it. It's just too hard to get them to hold still long enough to get it in their ear. It's very non-invasive. It's kind of like, you can kind of envision a tip of a ear thermometer kind of thing going into their ear, and it's pretty quick. It takes, as long as you're not fiddling around with it too much because it's not a good fit, it only takes less than a minute per ear. Mm-hmm. So it's pretty quick. And the equipment's called an OAE, which is autoacoustic emissions. That's what OAE stands for. It must be called an OAE something. But anyway, so we have the equipment to do that here, and we do offer it for all of our clients as part of their midwifery care, but we also offer it for other families, other home birth families or birth center families, or anybody really, for a nominal fee. Mm-hmm. So we do that on Thursdays if anybody needed to make an appointment for that.
Yes.
So yeah, the hearing screening is not as time sensitive, but it is still important to, and of course we have babies in care till 6 weeks, so we want to have it wrapped up by then. Mm-hmm. Sometimes you have to repeat the screen, so doing it at that 10-day visit is a good idea, and then that way that gives you the next visit to repeat it. Okay. To make sure that it gets caught, because sometimes they're just wiggly, or maybe they have a little fluid in their ear. Yeah,
I remember trying to do the screening with one of my children, so actually none of them got it done successfully, but I think it was my third one. I tried to get it done at the pediatrician's office, and it seems so much more involved than it is now. And it just didn't work. She was too wiggly and just like, it did not work. And then I never came back to it. But now it just seems like a lot easier. So,
and it's not perfect. Occasionally we can't get a good reading. I've had to refer a couple babies out, one who I just couldn't get a reading and one who didn't pass. So sometimes we do have to send you up the ladder a little bit for some more, which is the same with any of these screening tests. Again, they're screening tests.
And correct me if I'm wrong about this, because times change, but I believe that we cannot refer people to the pediatrician for a hearing screen here.
Yeah, they do not carry they don't have the equipment on hand to do it.
So they have to go to
So some of the best resources, Children's Hospital has a good audiology department. Kaiser actually has a really good audiology department. You would need to go to an audiologist, though.
Okay.
But I tend to send people to to Children's Hospital.
Okay.
And here in Denver, we have a number of satellite locations, and so some of the audiology departments also are at the satellite locations.
Oh, great.
Yeah, which is great.
That is really good.
So, yeah, the hearing screen, that's a new thing for us to be able to offer, and I'm really excited that we can do all of the pieces now, because we definitely were falling through the cracks, I think.
I think so, too.
So, that's one thing I was going to mention is that on all of these newborn screens, again, in public health terms, we talk about populations at risk, and out of hospital / community birthing. The community birthing population is at risk for not being screened for all of the
Oh, really?
screens. Yeah. So we're considered a population at risk.
Because we're like rebellious or what?
I think, I think so much is just those barriers. You just exactly described a barrier. It was a kind of a pain.
It's a pain to have to make another trip to go in. Yeah. So if your midwife has the equipment, that would definitely make it.
Yeah. So
easier.
I think that's one barrier. I think another barrier is, how is this information being presented to you?
Mm-hmm.
Are you being given information by your midwife about how important it is or not? It is really important. It's really, really important.
Yes.
I was on a Facebook group and a person mentioned, she said something like, I realized my baby didn't get the hearing screen or the PKU. I'm pretty sure she said PKU, but, and now I'm second guessing that, and I'm wondering if I can still get it. My midwife said I don't need it. And I thought, that wasn't a really constructive, informed choice discussion that happened.
Yeah.
So
I wonder what that conversation was like.
Yeah, I don't know, but it's, it's absolutely your choice as a client to decide what you want to do or not. But I do think it's important that you get that good information from your provider.
Yeah. I mean, all of the states I looked at, and of course, Colorado in particular, there are options for opting out on all of it. But I don't know why we would want to do that. It's, I mean, again, it's ultimately the choice of the parents, but, they're so important. So,
yeah. So we really encourage it and support it. And, I was going to mention, we actually don't charge for any of the hearing screening as part of your midwifery fee. But,
or any of the newborn screening.
What did I say?
Hearing.
Any of the newborn screen. So we include it as part of your midwifery fee. So we don't want finances to be a barrier, because that, of course, is another barrier.
Yeah, the newborn screening, the blood spot test can be kind of pricey.
They just raised the rate in Colorado to $110.
Okay.
So
yeah, so we include that in our fee, just so that, again, so that's not a barrier.
Yep, we just want to make it easy for you, because we want to keep you and your baby safe. So, all right. Well, that's all we've got today on newborn screening. You can check out, we'll have a blog post today, and I will also link back to the videos that I did for the New Steps program. I didn't do them by myself. The videos that I was involved in for the New Step program, so that you can watch those too. There's, for the midwives listening, there's some good collection tips. You'll get to see the Nedra technique demonstrated, because that's what I do. Funnily enough, that was a very, very difficult collection that I did for the video day.
Sometimes they're not perfect, but
no, but
we try really hard.
And then some days it's just like plop, 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 5 drops of perfect circles, but not that day. So
of course, since you were being filmed,
it was, maybe it was some nerves too. So that's what we've got today, and we're looking forward to our next week with you. But in the meantime, have a great week, and definitely do your homework on newborn screening.
Yes.
All right. Bye.
Bye.